All right, Dennis, would you please do the introduction?
Sure. I think all of you know Dr. Jim Heinrichs, who is one of our own here at St. Timothy's for many, many years. And I learned from him that I believe it was the 1st of May that Jim accepted the new position. I believe it's St. Louis County Department of Public Health. And it's a long title, but it's a division, department, infectious disease control responses, blah, 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 or something. Is that about right? But anyway, he's the guy that's in charge. He's the guy that's in charge of the COVID-19 and every other infectious disease, I guess, that St. Louis County. Hey, we're honored to have you here today. I won't take any more of the time that people want to spend to hear you. Thank you for being here.
Great. Thank you, Dennis. Can everybody hear me okay?
Yes.
Yes.
Okay, great. So like Dennis said, I made the mistake of volunteering to help with the COVID response with the county. I just figured I would do some hours volunteering for contact tracing. And the next day they called me and said, can you come in for an interview? And I said, well, I'm just volunteering. And I went in the next day, not knowing what to expect. And they said, well, we looked at your curriculum vitae and can you work full time for us? so that's what happened. That's what happened in May. So I've been with the department since then. And initially, most of what we did was trying to get policies together for people being able to pretty much stay at home and mask mandates, that type of thing. But then we had to review a lot of events that people were trying to put together, all the school sports, all the sporting activities, that type of thing, and worked pretty closely with Sam Page, who's a physician as well. And it's been a great collaboration. It's really a good leadership team. But as we all know, it's kind of had dips and turns since May, and we'll kind of go into some of that. But what I'd like to do is just give just a brief overview. I think all of you are pretty familiar with the virus and how it spread, that type of thing. So I'm not going to spend a lot of time on that, but I would like to spend some time just looking at what the county has been through, what some of the things that we have tried to do, some of the things we're still trying to do, talk a little bit about contact tracing, which I'm kind of in charge of, but also try to give a preview of some of the current controversies, what we can expect to happen, hopefully in the next 3 or 4 months. So I'll try to put on a little bit of a crystal ball, but it's interesting that when I started in infectious disease in 1980, I figured there would probably be one pandemic in my career, but I didn't expect to have two. We went through the H1N1 influenza outbreak in 2009, but this is a whole different deal and a whole lot more dangerous. So I'd like to spend a little bit of time on that, but leave some time, a lot of time, hopefully, for questions and answers, which I may or may not be able to answer, but at least it's a good dialogue. So with that, I'll just briefly kind of talk about coronaviruses. They basically cause disease in a lot of different areas, animals and humans, including bats, where this particular one may have originated, but they can evolve. And it's an RNA virus, which those of you who are familiar with DNA and RNA, DNA viruses tend to be pretty stable, like herpes virus, that type of thing, but RNA viruses tend to mutate quite a bit. HIV is an RNA virus, so it mutates constantly. And this virus will continue to mutate as well. It's been relatively stable, but when we hear about people getting reinfected with COVID-19, a lot of the studies suggest that it is a different virus that they're being reinfected with. It's not the same virus that's circulating. So this is going to change, just like influenza changes from year to year. But in animals, it can cause a variety of things, diarrhea in cows and pigs, a lot of respiratory tract infections in humans. It mainly causes kind of like the common cold, but with a couple of them, like the original SARS and with Middle Eastern respiratory virus, can cause significant mortality and pneumonia. Coronaviruses are named for the, like Susan was talking about, the little crown-like spikes on their surface, and they really were first identified fairly recently in the mid-1960s. But this clearly is a new virus that is causing the disease now. Where it emerged, I mean, initially there was question that it was in a wet market in Wuhan, but we're not totally sure how it emerged. But that's fodder for all the conspiracy theorists for sure. But it's still not totally clear. But there's pretty good evidence that this was not a genetically modified virus in some laboratory. It does appear to be a natural virus, but where exactly it got into the human chain in China is still a little bit unclear. As you know, cases have been detected in most countries, and the WHO in March 11th, 2020, not that long ago, finally described it as a pandemic at that time. It's a respiratory virus, although it does cause some GI symptoms in a lot of people, but it's primarily spread by direct inhalation of the organism, either in droplets, and now finally the CDC has agreed that aerosols can be a significant way. And that's the main difference there, is that droplets tend to fall to the ground within 6 feet after you cough. You know, they're fairly large droplets that contain the virus, but aerosols are much smaller, and they can spread up to 18 feet or so from somebody who's coughing or singing or any number of things. And there's some secondary spread, perhaps by touching an object with the virus present and then touching your eyes or mouth or nose. But I think the more we're into this, the more that seems to be less of an issue, where people don't have to be wiping down their groceries and this type of thing when we're worried about that particular mode. But it's mainly respiratory focus that we concentrate on. The symptoms, I think, have been kind of expanded. It's really totally diverse as far as what symptoms it can cause. There are 2 of us in the department that release everybody from isolation in the county when they have a positive test, and we reach out to them, find out what their symptoms are. And we just see a whole host of things. Right now, we're seeing just a lot of people that just think they have a sinus infection and get a little worse. But one thing that does seem to be almost specific for this virus is the loss of taste and smell. We see it maybe in 30 or 40% of people have that, particularly young people. And that's not something we're going to likely see with influenza as it starts to appear. So that might be something that helps us kind of distinguish the two. But anything can happen with this virus, and particularly in young kids, where usually in young kids, they're either asymptomatic. We'll see babies with it that just have a little irritability, a little congestion, and that's about it. And then they're better in a couple of days, and we monitor them for that period of time. So it's really a crapshoot as to what people are going to come up with. As I said, symptoms may be very mild or not present at all. And the thing that really distinguishes this virus from many others and from the earlier SARS is that it can be contagious as soon as 2 days before anybody comes down with symptoms. So whenever we investigate a case and do a case investigation on a positive test patient, we always ask them what they were doing 2 days before they got sick or 2 days before they got tested, because we know they can be contagious when they're not symptomatic. And then the virus can be present in very high viral loads, even during those 1 to 2 days before they become symptomatic. And then the day they become symptomatic and the days after, it slowly falls off. And we know that generally within 8 to 10 days, most people that have a relatively normal immunity are no longer contagious. So That's our CDC guideline. It's pretty much followed by any public health service. So if we have a positive case, we number one, find out when their symptoms started. And if they don't have symptoms, we have to go by when their positive test was. And then we count up 10 days. And at that point, if they don't have any fever for a day without Tylenol or et cetera, and they also have decreasing cough and symptoms, we do not consider them contagious after that point, and we can release them from isolation and go ahead and send them a letter if they need it for work or whatever to resume their relatively normal activities. But during that time before they become symptomatic and for those 10 days, they really need to isolate at home. And we make it very clear to allow them to do that. We even have a hotel at the Westport area called the Hawthorne that we can send patients to if they can't isolate themselves away from their family members. We'll offer that. They get food and a hotel room basically for the 10 days of their isolation if they so need it. So that's one thing that we can offer people.
Jim, can I ask a question there, or do you want questions at the end?
Interrupt me, that's fine.
Oh, I'm sorry. But so did that change from the 10 days? Because we were doing at the hospital for employees and staff calling in, I was taking calls for that. And we were doing 14 days from time of symptoms that they couldn't come back to work. So has that since changed? Was it at the beginning 14 and now 10, or?
Yeah, originally we were not releasing anybody till 14 days because so many of the early cases were in elderly nursing home patients, that type of thing. And they were still pretty symptomatic, frequently up to 10 days. But the data now through the CDC and through actual cultures of the virus to see what's there is pretty well solidified that. So isolation is the 10 days. Quarantine is a whole different thing that we'll talk about. So if you get sick and Tim's there with you and you're able to isolate yourself from each other, his quarantine would start the last day, beginning from the last day that you had close contact with him. But 14 days are when he could be incubating the virus and come down with the infection himself. But the isolation period is 10 days. And when you think about it, the 2 days before you're isolated, you're contagious. So it ends up being close to 14 days total, but it's 10 days from the onset of the symptoms.
Okay, thanks.
Yeah, and that, and that came into play frequently with healthcare workers because if they were asymptomatic, we would, they would be considered essential workers and could return to work as long as they were taking their temperature a couple of times a day, watching for symptoms. And as soon as they developed symptoms, they needed to go home. But during that period of time, they may have been contagious. So it was a mixed bag, but we just really didn't have any choice. And going forward, we're not going to have much choice now as the hospitals get more and more full. So isolation and quarantine are two, separate things that are very important to kind of talk about. So we also obviously worry about people that have a lot of underlying disease, so whenever somebody's positive, we ask them if they've got underlying lung disease, if they're a smoker, if they're immunocompromised. And before we release somebody that potentially was in the hospital, et cetera, we want to make sure that their symptoms are really decreasing before they get released. And frequently, quite honestly, when somebody has underlying lung disease and they're elderly, I'll usually, when a county employee becomes positive, I'm the one that has to do the case investigation on them normally. So I get to talk to a lot of folks that are in various stages, many of them asymptomatic, some of them quite ill. And one of the things that I frequently will ask them to think about getting is an oximeter. When you go to the doctor and they put that little thing on your finger, that's to measure your oxygen saturation. And that's one of the things that's tricky about this infection, is that people can get short of breath, can get pneumonia and not even realize it because they're too weak to do much else. And when they end up going to the emergency room, they find out that they almost need to be on a ventilator. So it's very important to kind of monitor that. And frequently you can get them on Amazon within a day or two, or Walgreens and CVS handles them too. They're maybe $30 or so. So I'll frequently, when I'm talking to employees of the county, if they're elderly, I'll just suggest that they have somebody get that for them and then just monitor their O2 sat, which should be like 97 or 98%. And just keep an eye on that, because it can be very sneaky and sneak up on them, and you don't want them to end up going to the hospital too late and end up requiring a lot of ventilation. As I said, some of the severe warning signs really are when you start having difficulty breathing or shortness of breath. Like I said, that can be very subtle. Pressure or pain in the chest certainly would indicate that you might have pneumonia, or this virus tends to attack blood vessels, so people can get what's called pulmonary emboli. They can get cardiac involvement, which is something you really worry about when athletes get this infection and they want to go back to playing their sports. I usually recommend that they get seen by a cardiologist just to make sure there hasn't been any damage to their heart related to the infection. And obviously, new confusion, particularly in the elderly, could indicate that their oxygen is low, or they're having stroke-like symptoms, which can happen also. And then obviously if they're bluish lips or face, meaning they're not getting enough oxygen, then that's not a good sign, and usually means that they are getting into respiratory failure.
What does an elevated temperature indicate? I've gone places like when I go play tennis, they take your temperature first.
Yeah. Yeah.
What does that?
We usually look at I personally think that anybody who has a 99.8 temperature might feel it, because frequently, whenever I go to work, I get my temperature checked. I'm like 97.7 in the morning, and most people are lowest in the morning. And if you get up to 99.8 or so, you're gonna, and you feel it. We kind of use an artificial 100.4 or 100 as kind of a barometer, but frequently, if you are even 99 and you feel like you have kind of a flu-like syndrome, that's a fever for you, and you should take that into consideration. They may not send you home if you go to work with that, but time and time again, we talk to people, well, I had a low-grade fever and I knew I needed to work. It was just my sinuses, and then we'll find out they've exposed a lot of other people, because that's all they feel. So yeah, you will get temperature checks, and some of those thermal readings are pretty inaccurate if you've been exercising a lot. Sometimes, it's a surface temperature, it's not your core temperature. So it's what most people do, because they don't want to put something underneath your tongue or anything like that and have to disinfect it and everything after that. So most of them are these thermal temperatures, which relatively accurate if you're normal, but if you've been running out in the sun or something like that, they may not be so normal. So I think we're all kind of familiar with how to stop the spread. Unfortunately, so much of this has become politicized, so that people don't want to wear masks. They don't want an infringement on their individual rights, but wearing a mask is incredibly important as far as decreasing the possibility that you're going to spread the virus to somebody else, and also to protect yourself from those large droplets. If somebody coughs near you, if you have a mask, it's very unlikely to get through that mask. The small droplets might, depending on a cloth mask versus an N95. And we can talk about the different masks if you want, but they all provide a lot of protection. Unfortunately, when somebody is in a household or when a school situation, even if they're all masked, the CDC does not consider that a huge factor as far as when we decide somebody is a close contact or not. we'd like to know that they're wearing a mask. We know it decreases it, but if you're within 6 feet of somebody and you've been with them for 15 minutes and they've been coughing, even if you both have a mask, we would still consider you a close contact if they have COVID. So it's evolving.
Cool. So Jim, I have a question on that you just covered, because the time has passed, but I had a coworker. We were both masked with surgical masks, and I also had protective eye gear on.
Mhm.
So, but I was with that person all day long,
Wow.
going in a large area doing flu clinics. So, what's the risk of that with a surgical mask per se? And I talked with him close to 6 feet, but not often. So that was not considered exposure at work because we both had proper PPE on, but would you consider that a risk then? I mean, the time frame's gone, so I'm not exposed anymore, but
Did you get quarantined at that point because of that exposure?
I did not.
Okay. Yeah, I mean, it's an evolving thing. Like just last week, the CDC changed their guidelines on that 15-minute rule, because what they found out is that in a jail situation, a corrections officer was interacting with some inmates, and it turned out that six of them were positive. He had maybe a minute contact with one at a time, but over the course of 24 hours, they went back through his time frame, because they had cameras, and found out that he had probably over 15 minutes of cumulative contact with those positive inmates. And inmates are urged to wear masks, but they may not necessarily do it very well. So he ended up coming down with COVID based on that exposure. So they changed their guidelines from, it's not just a total, a one spot of 15 minutes. It can be a cumulative time of 15 minutes over a 24-hour period. And that comes into play with teachers in a school situation. We had to quarantine like a whole school because they had a music teacher that was involved with multiple classes and was going, from student to student to student. She came down with infection. And so there was just a huge number, of students that were, at a table right next to her, even though she had a mask. We ended up quarantining most of the school just because of that situation. So in that circumstance—
Did any of the students develop it from the teacher?
Not that we know of. This was about 2 weeks ago, so some of those are probably still in quarantine. But when we're dealing with that kind of a situation and knowing that students can get infected and not have any symptoms, we might not know, unless we tested everybody, we wouldn't know. But we're just trying to keep schools open, but it's sometimes very difficult decisions on what's considered a significant contact or not. Schools vary by ventilation, by things like that. So there's the CDC, as far as the aerosol part of this, finally did say that in a closed space, like in an indoor setting, when people are with each other, the 6 feet rule is probably not sufficient. If you're in a closed room like that, you could be inhaling that virus for several hours. And Mimi, I think the surgical mask and the eye gear probably protected you a lot, but right now, if you describe that particular episode, we would probably put you on quarantine for 14 days. But you're a nurse and you might be considered an essential worker, and you might just have to monitor your symptoms real closely. One thing that we do recommend is if you're a close contact, the county has testing freely available, just a drive-through system, both in Sunset Hills and out in Berkeley, where I work. So we usually recommend that go ahead and get tested 5 to 7 days after your contact. That's when you're likely going to become positive. If you are going to become positive, it doesn't remove that from 14 days of your quarantine, because it can be later than that. But at least you would know if you're positive at that point, and, you know, isolate yourself at that point, and you'd worry about your family contacts even more at that point. So it's never a bad idea to get tested, but you want to wait until the time period where you might be incubating the virus before you get tested, not just right away.
Right, okay. Thank you. Oops.
Problem. And
So
the testing, the testing is problematic because there's a lot of different things out there. The gold standard is the so-called polymerase chain reaction, or PCR testing, that measures the actual genetic material, the RNA of the virus. And they're very accurate. And we primarily use those to diagnose somebody who has an active infection. Antigen tests are a new category that can quickly be done. So if you go to an urgent care and they offer you a 1-hour test, that's usually a rapid test that's going to look for parts of the virus, but not the RNA. And that's just going to detect fragments of the virus. But the big problem with those is that frequently, if you're symptomatic and you get one of those tests, it can be falsely negative. And so we never rely on that. If somebody has symptoms that might be compatible with COVID, they get one of these rapid tests, and some of the urgent care centers will say, well, you can go back to work, no big deal, you're negative. But if you're symptomatic, you need to demand the PCR test, because that rapid test could be falsely negative when you have infection. And we definitely do not recommend those when somebody doesn't have any symptoms, because it's even more likely to be either falsely positive or falsely negative. So it gets to be a little tricky with some of those. The antibody tests that some people offer can give you an idea whether you had an infection a month ago with COVID, but it's not going to tell you what's going on right now. And we use those primarily for prevalence studies to see how much infection there has been in the community. And I think next week we're going to have an initial report. WashU is doing a prevalence study for us that will be released, I think, next week to give an idea how many people in the county truly had infection. So that'll probably make the news next week or so. I don't know the results yet, but it'll be interesting. And then, like I say, when to get tested, it's readily available now. Get tested if you're in a high-risk situation and were exposed, or if we recommend that you contact, but wait 5 to 7 days after the event. And again, if you're notified by the county that you were exposed, consider getting the test 5 to 7 days after that contact. But you're still going to be on quarantine for those 14 days if that was considered a close contact. And then during that time, you want to maintain masking, you want to maintain social distancing, and quarantine until the testing comes back. There was a recent report just this last week where they looked at a large number of household contacts of somebody who was positive within the household. Say you become positive, Mimi, and you've got 3 children there and Tim there. Your household contacts after you become symptomatic have over a 50% chance of becoming infected. So that's pretty new information. We thought it was maybe 30 or 40%, but it's much higher than that. So it's, that's why it's so important to get those contacts under quarantine so that they're not out and about, making sure that they're not spreading it to somebody else. But it also applies to somebody that you may have been at a restaurant with or something like that while you were symptomatic, or 2 days before you were symptomatic. Eating, what we found is that many businesses, they do a great job of keeping their workers socially distanced while they're working, but they end up going to break rooms or lunch together, and they have their mask off, and boom, we have an outbreak. So I'm just going to go a little bit into our data from the county. This is a slide that I put together in September, and it looked like, we had that initial spike in cases in April and May. That's when so many elderly were admitted to hospitals and long-term care facilities had significant problems. And then it dipped down during the summer, and then we're all familiar that it started up after 4th of July. And the county has gone back and forth on restricting businesses from being open at more than 25% capacity or 50% capacity. And we thought we were kind of doing okay towards the beginning of September. We were actually falling in cases. And, you know, we were getting less than 200 cases a day or so, which is hard to keep up with at 200 cases a day. But look what happened now. This is the most recent data just from yesterday. And it shows that we went through that slow period where we actually were down to like 100 to 150 cases a day. And now we're back up to almost 300 cases a day. So we're not sure if that's going to plateau, if that's going to settle down, or if it's going to continue to go up through the winter months. And believe me, it's a huge stress on the staff that we have. So we're totally remodeling how we're getting a hold of people that are positive. So if somebody has a positive test, that gets reported to us theoretically, but it mainly gets reported to the state because that's the law. It's supposed to be reported to us within 6 hours, but frequently that doesn't happen. So they get reported to the state. We pull them down from the state each day, and sometimes the state gets backlogged. So that's why you'll see discrepancies in the number of cases each day that are reported. And then once we get them down from the state, we put them into our system. We get a hold of our staff that does do case investigations. They reach out to those people if we have a phone number. Sometimes we don't have a working phone number, or it's written down wrong, et cetera. But then we start case investigations on that, which can take up to an hour for each case. And when you've got 300 cases a day, you know, we're not going to get to it. On a good day, we maybe get to 30 or 40% of our positive cases. But the more we delve into that 1 hour conversation, we find that each of those cases may have 3 or 4 or 5 contacts, sometimes a significant number. And then that goes to a different team that then goes to contacting those contacts and making sure they get on quarantine. Because the whole idea is to try to box the virus in. This is something we also monitor. It's the percentage of testing that's done throughout the region that are positive. And as you can see, we dipped down in June to less than 5%. It came down to less than 5% in late September, but now it's almost 8 to 9% at this point. You'll see data on Missouri having about a 20%, but that's because there are spikes throughout rural parts of Missouri. Jefferson City, Springfield, Cape have huge increases right now. We haven't had quite that number of increases in St. Louis County, I think because of the masking mandate and things like that, but it's still much higher than we want it to be. You'll also probably notice that there's been a disproportionate rate in both Blacks and Hispanics in St. Louis County. This is kind of alluded to with this particular slide, where as you see, whites have less than 1,000 cases, whereas Black and African American have almost 3,000. Same with Hispanic. So we try to reach out as much as we can. And there's just a lot of demographic issues and why that's present. A lot of it, I think, is because a lot of white people that were working were able to shelter at home and work from home, whereas that's just not the case for Hispanics and frequently African Americans. So I think it's more a matter of exposure, but also inequities on healthcare and everything else.
Does 2 or more races mean mixed racial?
It depends on what they say. It could be that they're Hispanic and they put that down. So it's kind of a hodgepodge. Yeah. The other thing we found is that beginning in August and September, we found that there was a huge increase in 10 to 29 age groups. And you see here that But this was back in August. All of a sudden, we had 15 to 19-year-olds, and this when people were starting to go back to school and having a lot of social events. And it was kind of like pandemic fatigue. People were just getting together. So we had this big jump in 15 to 19 cases. That's settled down a little bit, as you can see here. But as middle schools have opened, you see that there's an increase in the 10 to 14 age group, primarily just because they're more getting together. So it's something we watch pretty closely because we have to, as far as giving school districts some options on when they should open and whether they should be a hybrid model or face-to-face, et cetera. These are some of the other statistics we keep. This is overall new cases by zip code, and you can see the blue have the highest number. So North County has been hit pretty significantly in most of the pandemic, and then Melville and South County, Afton areas as well. This is the most recent data for overall cases from 10/13 to 10/26, but we also subdivided by age 19 and younger, and this is what helps us give advice to school districts like Ferguson, Florissant, where the 63033 and 63034 are at the top of the thing. You know, they're still virtual because there's so much activity in their particular school district. The same happened with Rockwood, had a lot of cases for a period of time. So that's how this data can help us give some advice on when schools should open. And so just in terms of our options, you know, we've developed guidelines, we developed policies on school openings, gatherings, business capacity. The masking mandate, I think, has been very important. The council tried to strip that, but Sam Page vetoed that, and that veto was not overridden. So that's still in place. And social distancing obviously is incredibly important, not only for businesses and indoor dining, but also for schools to try to keep desks 6 feet apart. It's very difficult for that in many cases. We have lawyers on our team that help with legal orders on some of these factors, such as a masking mandate and businesses opening. But really, the main thing we can do is to try to contact trace people so that we can control the virus, which unfortunately is a significant challenge when we have so many new cases a day being reported. We provide drive-through testing. We probably do about 200 tests a day, at least, in the various clinics. And now we combine that with offering flu vaccine at the same time, which is helpful. We work pretty closely with the pandemic task force, which is on the news quite a bit, along with hospital systems. So we kind of try to have a unified message to the community so that people are getting the same thing. So I kind of went through how we do as far as contact tracing with isolation requirements, also with the quarantining requirements. And the whole system is really meant to do what this slide shows, where we want to test widely if people feel like they have been exposed, if they have household members, if we alert them that they were exposed. We want to test widely. We want to isolate all infected people, like we talked about, and then we want to obviously their household contacts. They're going to know about their situation, but we need to find out also people that they've been exposed to in the community that are going to get infected and expose other people. So that's part of contact tracing, where you've got to find other contacts outside the home so that you can get a hold of those and keep them from contacting other people and infecting other people. And then the quarantine, basically self-isolate for 14 days and then go back to trying to box it all in. Some of the current things that I think everybody's kind of worried about, and I know I'm starting to run out of time. I can either take questions at this point, but everybody's worried about the vaccine. Tony Fauci, who is pretty much very close to one of the vaccines because it was developed by the NIH, at a couple of meetings I was at this past week, is not really saying that the vaccine is going to prevent infection at this point. The hope is that it can modify the infection if somebody becomes infected so that their symptoms do not progress to the point where they're in respiratory failure, that type of thing. So that may be the best we can expect from a vaccine at this point. I read in the New York Times yesterday that Pfizer has all their people enrolled that they want to get enrolled. I think Moderna also. These are two vaccines that are probably closest to having some numbers on. And in terms of the Pfizer vaccine, they had like 42,000 people in this particular trial, and they're waiting to see a certain number of infections. When they get up to a number of infections within that 42,000 group, then they can break the code and decide whether placebo and versus vaccine was significantly different. And that'll give us some idea how effective the vaccine is going to be, but that may not be until December that they accumulate enough cases to be clear. The only good thing about the surge we're having right now is that a good number of those people that are on these vaccine trials are probably being exposed to the virus, which means that we might have some better idea how the vaccine is protecting or not, just based on those numbers. There's a big concern about how long the vaccine will work. Because this is an RNA virus, it may be like the flu vaccine where we might have to have a different vaccine every couple of years. All of that's a possibility. We're far enough into the pandemic now that we're seeing some people that appear to have to be reinfected. And there's a lot of research on how likely that is. I think I was just in a meeting yesterday where they said there's been about 120 people in the country that may have been reinfected. And what the CDC tries to do in that circumstance is to look at both viruses if both samples were available and collected, and then they look to see if there's a mutation in the second virus that might be significant enough that this is a new virus that they were exposed to and they truly are reinfected. The reinfection appears to be a little less likely to be as severe as the first infection, but that's totally, that's not always the case. And some people can be very severely ill if they get reinfected because they may have been relatively immunocompromised with the first infection. The whole issue of herd immunity comes into play. Where in most cases like measles, unless you have 60, 70, 80% of the population either have been infected with the virus or being vaccinated against the virus, to be able to protect the whole population, you need that kind of percentage. And that's problematic because we don't know what percentage of the population will agree to get a vaccine. There's a lot of anti-vaxxers out there that are going to be difficult to get to take the vaccine. There's a lot of innate issues with African American population, I think, not wanting to get the vaccine until we know more about it, as they're more disproportionately infected by the virus. So that's going to be a big push once a vaccine does become available to try to get those high-risk populations vaccinated. So it's going to be a long haul. And I think if a vaccine becomes available by the time it can be released and get into the general population, we're looking at spring of next year before probably a significant enough people have been vaccinated. So I think masking and social distancing are just going to become part of our culture. Just like it is in many Asian countries right now. So I'm going to stop there and take any additional questions or any additional concerns. And thanks for inviting me.
Thanks, Jim. I have a question, Leslie. I was just wondering, do you see any changes in mortality rate How is the virus changing? Do we see any differences in potency or as it's mutating? And then like who's affected as far as hospitalizations? We have many more young people being infected, but are we seeing changes in hospitalization?
Yeah, so that's a great question. I mean, early on, the mortality rates were significantly high, upwards of 30% sometimes. And a lot of that was related to the elderly population being the ones that were hardest hit early on. The hospitalization rates are gradually increasing to the point where hospitals are reaching capacity again, starting to cut back on elective surgery, that kind of thing. The mortality rate is lower now, and I think most people see that this is not a function of the virus being weaker, but the fact that it is infecting a younger population that handles it better. But in addition, we are learning that some things like corticosteroids given when somebody requires oxygen and some other modalities do have probably decreased the mortality by about 30% just from the current care that they're getting. But again, this is something that's evolving, and it's very clear that we don't have great treatments for this virus yet. There's not a lot in the pipeline that looks very promising. Remdesivir, which is one of the antivirals, appears to have some mild effect on decreasing length of stay, but has no effect on mortality. I think Decadron, when somebody requires oxygen when they're that ill, does have a significant impact on decreasing their likelihood of going on to respiratory failure and significant organ damage. But these are people that are very sick to begin with. There's no magic bullet unless some of these monoclonal antibodies become available, but they're going to be very expensive and not very available to most people. So there's not a lot out there that looks very promising as far as treatment right now.
So doesn't look like the virus is getting weaker or anything like that.
It does not. It
No.
does not.
Okay, thanks.
Yeah, and hospital systems, I think, because there's so much activity and so many cases in rural Missouri, a lot of those are overwhelming the hospitals in those areas, and a lot of those patients are being shuttled. I think maybe 20 or 30% of the new admissions to the hospitals in the St. Louis area are from out state. They're from other jurisdictions where their hospitals can't keep up with the whole situation.
I have a quick question. This is Susan, Jim. We've all had our temperatures taken multiple times over the past month. Mine always range between 97.1 and 97.3. So has 98.6 been discarded as the standard? I'm healthy, I'm fine.
Yeah, no, I mean, temperature is a diurnal variation, and most people's are lowest in the morning, and that's when most people get their temperatures checked when they go to work, that type of thing. And then it gradually will creep up to a mean of 98.6 by the afternoon. But frequently, it doesn't get there in a lot of people, and that's why you got to listen to your body. If you feel like you have flu-like symptoms and you take your temperature and it's less than 100.4, that doesn't mean you don't have an infection. I joke with people that 100.4 was actually established by surgeons who use that barometer as a way not to be called in the middle of the night when one of their post-op patients had a fever. So that's true. So that's where 100.4 became the standard. But you and I both know that you can feel very sick from a common cold or from the flu and have a 99 temp and still have the same muscle aches and pains and everything else that you might have when you're 103. So it's just a guideline, and it's a very imperfect guideline for this infection because so many people, particularly the young, just have no symptoms and no fever. And even the ones that I talk to that are in their 60s, they may have 100-degree temp for one day and that's it. But they're coughing and they're having a lot of muscle aches and pains, or a lot of headache. There's a lot of this loss of sense and of taste and smell that's really quite unique. And it can take 6 months to come back. That's the trouble with that. It's not irreversible. It doesn't appear in most people, but it does take a while to come back. So you may be releasing them from isolation when they're still having that particular set of symptoms.
Jim,
Thanks.
Mark,
Oh,
the Europe is doing very bad, and there are indications, and it's not scientifically confirmed, but there are indications that the worsening is worse than what the models would have predicted. And the models were based on some slackening of measurement, tiredness, etc.
Right.
Do you feel, are there indications in the US that the contagiousness of the virus or the character of the virus has changed? Or is that just a political smokescreen in Europe?
I think there's more of a realization that aerosols can spread the virus. So, I mean, I think this has a big impact, I think, on indoor dining, indoor gatherings. It's very worrisome in terms of the holidays coming up, where unless you have a bubble within your family, you really have to rethink who you're gonna allow into your house, because these aerosols, I mean, you see, the New York Times had a little pictogram where they showed what if somebody coughs and they don't have a mask, that virus can stay in that room for upwards of an hour, as long, and as much as 18 feet away. So you're breathing that in, and in a indoor dining, when your mask is off when you're eating, that's a particularly dangerous period of time. So I know I think New York still is not allowing indoor dining. And I think we might have to pull the lever on that one too here in the county. I think that's one of the things we're talking about, because there's not a lot else we can do right now in terms of trying to, we push people to wear a mask. That's tough to enforce those kind of things. There are counties all around us that don't have that mask mandate. St. Charles doesn't, Franklin County doesn't, Jefferson County doesn't. So we have all of these competing people at this weekly conference that we have with the mayor and with Sam Page and all their elected officials, and they just are totally resistant to mandating the mask. And Missouri hasn't helped because Parsons hasn't made this a statewide mandate, and here we are with all the rural counties having huge upswings. So I think we really shot ourselves in the foot by not having a statewide mask mandate. It's one of the few things that really does seem to work.
And so I know that there's more questions. Unfortunately, we have to wrap this up because the service is starting in a couple of minutes. Jim, if it's okay, can folks email you with additional questions or follow-ups?
Yeah, for sure.
And if anybody needs that information, you can reach out to me. So first of all, thank you, Jim, for all that you're doing. We appreciate, going from a small volunteering job to a full-time job for many months and with no end in sight. So thank you for everything that you're doing. Thank you for giving us this presentation today. We sincerely appreciate it. I know I learned a lot myself. Before Mother Liz left, she asked me to remind everybody that there is an Evensong tonight at 5 p.m. So please tune in for that experience. And thank you all for being here today. Appreciate it.
Thank you all.
thank you, Jim. This was wonderful.
My pleasure.